assistant and the founding director of the Tulane University Pathologist Assistant Program. Sarah enjoys teaching anatomy, pathology, histology, and advocating for the pathologist assistant profession through her Instagram account @passion4pathology. Please welcome Sarah Garner. All right, Sarah, you are live.
Thanks, Ian. Can you hear me?
Yep.
Okay, awesome. Well, let me know if my audio goes out because I'm using earphones.
Sure thing.
All right, so today we're going to talk about some GI embryology, and specifically we're going to talk about a couple different things and how they relate to surgical pathology. So our objectives for today, we're going to talk about just a basic review of anatomy and embryology of the GI tract, and we're going to pay particular attention to the midgut and the foregut. And then we're going to apply these principles of embryology to congenital anomalies of the GI tract. And we're going to talk about how this embryology is important for surgical pathology specimen grossing, in particular for the GI tract specimens. So I know that a lot of people really don't like embryology that much. I feel like this is a really difficult class at first. And so oftentimes I feel like it gets a little bit overlooked. But it is very important for PAs at least to have a regular review of it, because in order to really understand the normal anatomy, it's important to understand the embryology and how everything actually forms. So the other thing that we need to talk about is congenital anomaly. So if you don't understand how these structures should normally form, then it's difficult to understand any of these anomalies. So we'll touch on those a little bit. And then also, in order to really understand surgical margins for GI specimens, it's important to understand that embryology. Otherwise, you're just kind of memorizing stuff, and we never want to memorize stuff. We want to understand it because that makes us better PAs, right? So the gut tube itself, it's originally from the endoderm, and it's created by some body folding during the 4th week mostly. And this folding is going to start, and it's going to form 3 different areas. So you're going to have 2 blind-ended areas on either end. So this is going to be your foregut, which is over towards the mouth side, and then the hindgut, which is going to be over at the distal side. And then in between those, you have the midgut, which I think is the coolest part. It's actually open up wide to the yolk sac through this duct called the Vitiline Duct, or also the Omphalocele Mesenteric Duct. And so we'll get into that a little bit. But in order to really understand the different parts of these foregut, midgut, and hindgut, it's important to understand the actual anatomical structures and the blood supply. So here, this is just kind of color coding the different parts. So you can see the pharynx, the esophagus, the stomach, and the proximal duodenum. This is like the embryologic crude drawing of that. And then you're going to transition into the midgut. So the blue is the foregut here, and then the pink is going to be your midgut. So this is going from the rest of the duodenum all the way through about the proximal 2/3 of the transverse colon. And then you transition into the hindgut here, which is the rest of the transverse colon all the way through the proximal part of the rectum. And so these may seem like kind of random orientation or designations of these different spots, but it's actually evolved based on the blood supply. So here you have a lot more branches of the abdominal aorta here, but 3 of the main branches are the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. And so where these arteries actually supply blood to, that's how the foregut, midgut, and hindgut are separated. So I wanted to do kind of a live dissection with you guys from the lab, but we were worried that the streaming might not go so well. So I recorded this video a couple nights ago for you, just to review some of the anatomy and the blood supply. So hopefully we can get this to play.
Yep, I'll start that up for you.
Stomach with the greater omentum all attached. Now, if you flip up the greater omentum, remember that's usually attached to your transverse mesocolon here. So this is your transverse colon, and here in the middle is your small intestine. Remember that your large intestine is like a picture frame. So you have cecum, ascending colon, hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid colon, rectum. But in the middle of that, you have your small intestine here. So all of this is going to be your small intestine.
Let's try this again. It should be playing.
Got stomach with the greater omentum all attached. Now, if you flip up the greater omentum, remember that's usually attached to your transverse mesocolon here. So this is your transverse colon, and here in the middle is your small intestine.
On the YouTube
remember that your large
But no
intestine is
audio.
like a picture frame. So you have
No, the audio's going now.
ascending colon, hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid colon, rectum. But in the middle of that, you have your small intestine here. So all of this is going to be your small intestine. So the GI tract itself is split into 3 different parts. You have the foregut, midgut, and hindgut. And these are all developing a little bit differently embryologically. And to define which one's which, it's really based on the actual blood supply of these. So the abdominal aorta, 3 of its branches are the celiac trunk. That's going to supply the foregut. You're going to have the superior mesenteric artery that's going to supply the midgut, and then you're going to have the inferior mesenteric artery that supplies the hindgut. And in order to understand the embryology, it's important to first understand which organs are coming from which area. And to do that, you first have to understand the blood supply. So we'll go over the arteries, and we're just going to go over some of the main ones. We're not going to go over all the branches. But here, this would be that greater omentum. So here's our stomach, right? So our celiac trunk is right up here. This would be the celiac trunk. And remember, that has 3 branches. You have your common hepatic artery over here. It has a bunch of branches, but mainly it's supplying the liver, the gallbladder, and a little bit of the stomach and duodenum, and actually a little bit of the pancreas too, all of those branches. Then you have the splenic over here. It's kind of going behind here. It's hard to see from this view, but it's back here. And then this one is your left gastric artery. So splenic is obviously going to supply the spleen, and then your left gastric is supplying part of the stomach here. So we have the liver, the gallbladder, the stomach, actually part of the esophagus as well, and then part of the duodenum and part of the pancreas. So all of those are going to be supplied by branches of the celiac trunk, and so all of those are going to be part of the foregut. Now the midgut, again, that's going to be supplied by branches of the superior mesenteric artery. So to find the superior mesenteric artery, we have to kind of move this out of our way. So this is our stomach and our greater omentum that we moved out of the way. So now what we can see here, this would be pancreas, right? And then this is duodenum. And remember, the superior mesenteric artery and vein travel right behind the pancreas here, right, basically right at the neck of the pancreas, which is important for Whipple specimens. And here you can appreciate why. This would be the head of the pancreas, the uncinate process. This would be the neck, and the superior mesenteric vein is right here, and the superior mesenteric artery is right here. So both of those travel right back here, which is why that groove for the superior mesenteric vessels is so important for a Whipple. But I digress. So here, this would be that superior mesenteric artery, right? And we said that this is going to supply the midgut. So what is the midgut? The midgut starts basically right where the foregut leaves off. So the foregut is going to supply about the first half of the duodenum through the superior pancreatico-duodenal arteries, which actually you can see right here. Beautiful. So the superior pancreatico-duodenal artery, you have an anterior branch and a posterior branch right here, and that blood supply is going to end about halfway through the duodenum. So the inferior or distal part of the duodenum is going to be supplied by the inferior pancreatico-duodenal artery, which you can actually see right here. And that's coming directly off the superior mesenteric artery right here. So it's the first branch of the superior mesenteric artery. So we have the distal half of the duodenum, and then we'll have all of the rest of the small intestine, so the jejunum and ileum. And so you can see these branches very well. And notice how tangled this gets and how confusing it can look. And once we talk about the embryology and the rotations, it will be apparent why, because all of this, it literally gets tangled during development. So here, this is still at superior mesenteric artery, so these would be the jejunal branches of that, and then here, these would be the ileal branches of that. These are the corresponding veins. And then here's the terminal ileum and the junction with the cecum. So here's the cecum, this is the terminal ileum. So this branch right here is still a branch of superior mesenteric artery. This is your ileocholic branch, and that's supplying the terminal ileum, the cecum, and then the appendix. I don't think this person has an appendix. But it would also give off a branch to the appendix, okay? And then it also is going to supply the ascending colon via the right colic artery right here. So again, here's superior mesenteric, here's the right colic artery coming off, going to the ascending colon, and then it will supply the transverse colon as well. And that'll be through the middle colic arteries, which I kind of just flipped them out of the way. But this is going to supply the first 2/3 of the transverse colon right to about this level. So here's the level of pretty much where it ends. So this is that splenic flexure or the left colic flexure. So the blood supply from the superior mesenteric artery ends about here. Then the inferior mesenteric takes over, which means that this is the end of the midgut. So to recap, we had the midgut going from the distal half of the duodenum, jejunum, ileum, and then the first part of the colon. So we have the cecum, the ascending colon, and then the first 2/3 of the transverse colon. Okay, now we're moving on to the hindgut, which is supplied by the inferior mesenteric artery. So here's that abdominal aorta. This is your inferior mesenteric artery, and it is going to come and branch to the left colic artery here. These are some of the branches of left colic artery. Those are going to supply that descending colon. Then you'll have a couple sigmoidal branches supplying the sigmoid colon here, and then you'll have this branch right here, which is your superior rectal branch, and that's going to go down and supply the superior part of the rectum. It's about the superior 1/3 of the rectum here. So there is also a communication here, the marginal artery, which is important anatomically, but for our purposes for embryology, not super important. So inferior mesenteric artery here supplies the hindgut. Hindgut goes from the distal 1/3 of the transverse colon, the descending colon, the sigmoid colon, and then the superior part of the rectum. So that's the blood supply, that's the different foregut, midgut, hindgut. And again, notice how tangled those were, and we're going to see why when we talk about the embryology next.
All right, Sarah, that was an amazing dissection. I'm just going to pass it back to your slides.
Awesome, thanks. It's so cool what we can do with technology now. This is crazy.
Isn't it? All right, go ahead.
All right, so that showed you the different blood supply, and then I put the pictures in here as well in case you wanted to come back and look at them later. These are the same pictures. These are from the original Gray's anatomy, but here you can see superior mesenteric artery, and then here you can see inferior mesenteric artery. So how do these things actually form? This is what we're really concerned with for today. So we start off with the flat trilaminar disc, and this is at about week 3. And this is then going to kind of elongate to form this cylindrical structure. And as that's happening, you're going to be forming the yolk sac out here. And you're also going to be forming the amniotic cavity over here. So you've got ectoderm, and then you've got the mesoderm, and then your endoderm layer here. Now at this point, the mesoderm, there's 3 different parts of it. So the first part that I put the P here for, that is the paraxial mesoderm. And then you have the intermediate mesoderm here. But for our purposes today, what we're really concerned about is the lateral plate mesoderm here. So the lateral plate mesoderm is going to form 2 different, layers of mesoderm that are actually going to form the peritoneal structures inside the abdominal cavity. So the yolk sac itself is secreting some extra embryonic mesoderm, which is this pink out here, and it's going to kind of meet up with one of these layers. So the lateral plate mesoderm here is going to extend into its 2 layers. So the splanchnic mesoderm is going to come outwards this way and kind of meet up with this other mesoderm to encircle the yolk sac. And then the somatic mesoderm coming from that lateral plate, that's going to come out this way, and that's going to go up and surround the rest of the amniotic cavity here. So this is going to be really important when we're talking about the peritoneum. So just keep this in mind for now. So we had the flat trilaminar disc that is now expanded to this kind of cylindrical shape. And then at about week 4, we're going to start to fold. So there's 2 different types of folding that are actually going to happen here. You're going to have some cranial-caudal folding, which is what gives us this kind of general shape here. So you'll form the cranial end, and you'll form the caudal end. And that's where you're going to start to have the pharyngeal arches up in here, the foregut, and then at the tail end or the caudal end, you're going to have the hindgut here. But now remember I said that the midgut is going to be kind of opened up to the yolk sac, so that's going to be in the middle there. So this would be looking at it from the sagittal view. So this is a sagittal plane, and we're looking at it from the side essentially, and this would be that craniocaudal folding. But what we're really concerned with right now is the lateral folding. So the lateral folding, if we go back to this view, this would be like a face-on view here, and you're seeing that this layer of ectoderm here, so this part of the amniotic cavity, it's going to start to fold downwards on both sides. And as it's doing that, it's going to bring this somatic mesoderm with it. So what you kind of get is this. So we had that amniotic cavity expanding here on both sides. And as that's happening, you start to form this structure here, which is that Vitiline duct, and that's going to connect the primitive gut tube, which is here, with the yolk sac out here. And notice that as this is happening, it's still pretty much completely encircled by that splanchnic layer of that mesoderm, okay? So we're bringing the amniotic cavity walls out laterally and kind of squeezing in that endoderm, and that's what is forming this actual duct here. So a little bit later, about week 5 or 6, the actual Vitiline duct is going to close. So it's going to start to obliterate here. And that's going to allow these two parts of the wall to kind of start to come together. So the Vitiline duct should disappear essentially. And then this part can close off here. So this part is going to close, and that's going to start to form the actual gut tube in the middle here. But hopefully this is sounding familiar thinking back to school, because if this doesn't happen, if that Vitiline duct does not obliterate, that's when you can get something called a Meckel's diverticulum. So a Meckel's diverticulum is a true diverticulum, and it typically is going to project from the mesenteric wall of the ileum. And I'll show you why in a couple slides, but basically what it looks like is this. So it'll just be this little outpouching coming off a part of the ileum. And typically it's going to be within about 2 feet of the ileocecal valve. So it can be kind of anywhere along here on the ileum. So hopefully you remember the rule of twos. This is good for Meckel's diverticulum because it affects about 2% of the population. And like I said, it's going to be found within 2 feet of that ileocecal valve. It's typically going to be about 2 inches long, and it is about 2 times more common in males than females. And the most common age of presentation is typically 2 years old. Now, of course, there are some that go completely unnoticed. They're asymptomatic, and that's exactly what this case was. So this is from an autopsy case, and this was just an incidental finding when I was opening up the bowel. And I got really excited about it because it's a Meckel's, and they're not super common. But this one, it was completely asymptomatic, no problems at all with this. But it's pretty variable. Sometimes you will have some symptoms, and it just depends on how severe it is. So there's a couple different ways that it can stay attached. So it can be just a little diverticulum like we just saw, and it's not really connected to the abdominal wall anymore. Or it can actually remain attached to the umbilicus in a few different ways. So one way is you can actually have a true fistula, so you can have a communication between the ileum and the abdominal wall. You can have a fibrous band here that connects the ileum to the abdominal wall, but it's not an actual open fistula. You just have kind of a cyst in the middle. So that'd be an Omphalocele cyst. Or you can just have this fibrous band here where there's no communication at all. There's no cyst. You just have this fibrous band right here. And this, even though it's just a fibrous band, this can cause some problems for the patient. If this part of the ileum is kind of stuck to the inside of the abdominal wall, you can imagine that if this doesn't rotate properly, you can get complications later in life, such as volvulus or intussusception. You can get ischemia in that area of the bowel. So depending on which variant of the Meckel's diverticulum you get, there are going to be different levels of symptoms in the patient. But assuming this goes on normally, so we get the Vitiline duct completely obliterating, and we start to close this part of the tube, what's going to happen is that's going to fully close here. So this yellow is the endoderm that's actually forming that gut tube. So what happens to the mesoderm that's surrounding it, remember that this mesoderm out here, that is your splanchnic mesoderm. And so that's going to stay around the gut tube here. And then the somatic mesoderm is going to remain more along the body wall here. So I'm drawing all over this, but here, this entire thing in here, inside the pink, this would be inside that peritoneal cavity, okay? And then back here, this would be retroperitoneal. So remember that the blue was ectoderm, and so, let me erase this. So if this blue was the ectoderm, now we have a whole layer of ectoderm covering the outside of the body. So this is what's going to eventually form your skin. And then here, this would be that peritoneal cavity. And then you have the mesoderm still covering that gut tube. That's going to be important in a second. Now, another thing that can happen is if you have a defect here, so we had our Vitiline duct closing fine, but now if our lateral walls don't fully come together here to make this nice closure so that you get the skin coming from the ectoderm here to completely close the anterior abdominal wall, what can happen is you then get gastroschisis. So here, this would be a problem in the abdominal wall, and it's typically going to be right at the level of the umbilicus, but it's not in the midline. So it's more commonly found right to the right of the umbilicus. And what happens is you get herniation of these intestines through the abdominal wall and directly into the amniotic sac. So if we go back and look at this, well, that one's written on, but go back to this one. This layer of blue we said was the skin. Well, it's going to form the skin. And then all of this space in between the two blue lines, that's your amniotic cavity. So if that skin doesn't close, you're essentially just outpouching your intestines here into the amniotic cavity. And so those are going to be exposed to all of the fluid in there, which can be really bad for the intestines. So it's not covered at this point by any peritoneum. It's just the intestines go through the abdominal wall and they're out inside the amniotic sac. And so the amniotic fluid in there can cause irritation, inflammation of the intestines, and they can actually become necrotic. And so at this point, you want to be monitoring the mother with regular ultrasounds, and the baby may need to be delivered a little bit early to prevent that degeneration or necrosis of the intestines. Now, gastroschisis is frequently associated with other malformations. So if you ever see this on a search path specimen or an autopsy case, you definitely want to check everything very thoroughly because it is often associated with other findings. Like I said, it's typically going to be right to the right of the umbilical cord, so it does not go directly into the umbilical cord. That's important. It's just going to the side of it, and the reasoning behind this is that the abdominal wall did not fully close. So you don't see a sac, you just see intestines kind of outside the body. But going back to normal, so assuming this all closes very nicely, we get, the layer of skin here closing, we have our somatic mesoderm here, which is eventually going to form the parietal peritoneum lining the inside of the abdominal wall here. So this is all normal. So what is going to happen after that? Well, you have to somehow connect this layer of mesentery here, which is the splanchnic mesentery, with the somatic, or not mesentery, peritoneum. So you need to connect the splanchnic mesentery here with the somatic mesoderm here. And so this portion right here is going to fuse, and it's going to form a dorsal mesentery. So if you remember a mesentery, it's literally just a double fold of peritoneum. So you've basically got the splanchnic mesoderm coming up here and the somatic mesoderm coming here, and they fuse together and form this double layer, which is the dorsal mesentery. And this is a super important concept to understand because this is what's going to make the difference between something that's intraperitoneal and something that's retroperitoneal. So here we've got this dorsal mesentery that is suspending this entire gut tube, and it's inside that peritoneal cavity. So this by definition is then intraperitoneal. Anything that is suspended inside that peritoneal cavity with a mesentery is going to be intraperitoneal. So at this point, everything is intraperitoneal, everything is developing inside that peritoneal cavity. The next thing that's going to happen is about week 5, the ileum is going to start to elongate really rapidly. So this is going to form what we call the primary intestinal loop. And so it forms this kind of like hairpin loop here, where you get a cranial portion of the loop here that I've colored green, and a caudal loop here that I've colored red. And so this is then going to be pushed out or herniated outside of the body. And so the reasoning for this is you're elongating this ileum very rapidly. It's growing very quickly, and there's really nowhere for it to go. So you have, other organs in there. You have the liver, you have the stomach. Those are all developing rapidly as well. And so there's not really any room in the abdominal cavity for this to stick around. And so it's going to be pushed out or herniated into the umbilicus, which is exactly what's happening here. So it's being pushed out. And as this happens, it actually rotates 90 degrees. So this is the first rotation. This is important. And here you can see that it's kind of still attached out here by that Vitiline Duct. Now, it's then going to come back in and rotate again as it's doing so. So the superior mesenteric artery, remember, it's going to supply the whole midgut. So the superior mesenteric artery is kind of coming out into the umbilical cord with the intestinal loop. And at this point, it's going to rotate another 90 degrees around that superior mesenteric artery. And then it's going to come this way. So the green part, that cranial loop, has now rotated again. So another 90 degrees, pushing it more towards the right on the picture, but the left on the body. And it's pushing this portion, which is that caudal loop. So this is like the primordial cecum here, and this little guy is the primordial appendix. It's pushing it all the way up into the right upper quadrant. So as that happens, obviously that's not in the correct position because we know that the cecum needs to be down here, right? So we're going to have another 90-degree turn here. So to kind of summarize, because this is a lot, the ileum grew really rapidly, and all of the other organs are growing pretty rapidly. So this causes all of this to be herniated outwards, and it's going to rotate 90 degrees as it's doing so. It's then going to rotate another 90 degrees around the superior mesenteric artery, and that brings us to this point where we're kind of going back inside, but we're not in correct anatomic position quite yet. So there's going to be one last rotation. This is yet another 90-degree turn. And at this point, we've now brought our cecum from the right upper quadrant down here to where it should be in normal anatomic position. So this should look, fairly like normal anatomy. We've got our small intestines in the middle. We've got our cecum and our ascending colon here. And then everything looks, fairly normal. So if something goes wrong at this point, this is going to cause another issue, right? So if our intestines don't fully retract back into the abdomen, which should be complete by about week 10, as it's saying here, if that doesn't happen, that's when you're going to get something called an omphalocele. So this should be familiar. This is when you get the intestines that are going through the abdominal wall, kind of like we saw earlier with the gastroschisis, but this one looks a little bit different because it's actually in a sac. So these are pushed out inside that amniotic sac, but they're covered by peritoneum. So these are going to be inside a peritoneal covering or a sac within the amniotic sac. So that's kind of confusing, but basically what that means is the intestines are not directly in contact with the amniotic fluid here, and they're protected by this sac of peritoneum. And notice the location of this too. This is kind of within the base of the umbilical cord. And this is why it's called an omphalocele. So seal is kind of, sac, and then omphala is referring to the umbilical cord. So this is literally the intestines are still just stuck out in the umbilical cord. So if we go back, normally they should be out in the umbilical cord here. That's totally normal. That's just natural herniation that happens during development. But the problem in this case is if they don't fully come back in. So if they don't fully come back in by week 10, you get this, which is the omphalocele. Okay, so omphalocele, this is, not super uncommon. It's about 1 in 4,000 births. And this one, if you try to think about this rationally, if you're thinking, okay, well, these are surrounded by a peritoneal sac and these are kind of protected from that amniotic fluid, then these would probably be less likely to be, worse off for the patient. But it's actually the opposite. So here, these are protected inside that peritoneal sac, but the problem with this is usually, or I guess not usually, but a good bit of the time, these are going to have some associated chromosomal abnormality and also other congenital abnormalities. So it's not inherently the omphalocele that's worse off than the gastroschisis, but it's the other problems associated with this, like the chromosomal abnormalities and the congenital abnormalities that are going to cause a higher mortality rate in omphalocele. And I'm pretty sure I put that as a question. Hint, hint. Now this one, you don't want to confuse this with an umbilical hernia. So an umbilical hernia, you should see skin here. So this is essentially when you have intestines protruding through what's left of the umbilical cord, so the umbilicus here. But you should see skin. So even though at first glance it may kind of look like a sac similar to this, it's not a translucent peritoneal sac. It is instead just a skin covering here. And these are fairly common congenital issues, but they do typically resolve within the first 2 years of life. You can also get them later in life as an adult, but that's kind of outside of the scope of our talk for today. All right, so we had the elongation, we had the herniation into the umbilical cord, we had some rotations, we had our Vitiline Duct closing, and then we had our last rotation, and we're now in anatomic position. But are we done at this point? The answer is no. So we still have one more step here, which is that the ascending and the descending colon are both kind of shoved against the posterior abdominal wall. So that's these. And as they're shoved against the posterior abdominal wall, what's going to happen is the dorsal mesentery that suspends them, that we talked about earlier, that is going to essentially just disappear. And as that happens, the posterior part of the ascending and the descending colon are going to fuse with that posterior abdominal wall. So now these are now secondarily retroperitoneal. So why do we call it secondarily retroperitoneal? It's because they developed inside that intraperitoneal cavity like the rest of the gut, but then they're pushed towards the back and become retroperitoneal because they fuse to that wall. So originally they looked like this. They had the double layer of peritoneum here, aka your mesentery, and they were suspended in the cavity. But as the gut finishes rotating and the pressure inside the cavity kind of pushes them this way, the posterior or dorsal mesentery disappears and they fuse to the wall, and thus they are secondarily retroperitoneal. So this kind of shows that. So everything that we talked about is intraperitoneal at first. And then we said the ascending and the descending colon are going to become secondarily retroperitoneal. So hopefully that makes sense at this point. But what else is colored pink here? So what else am I highlighting as secondarily retroperitoneal? So we have the duodenum here, and then we have the pancreas here. So why are these secondarily retroperitoneal? So why are they not just originally intraperitoneal? Or why do they not stay intraperitoneal? So this is kind of a separate process. So remember that the esophagus and stomach and all of that are coming from the foregut because those are all supplied by the celiac trunk, right? So here, this is the very primitive gut tube. You just have one nice cylindrical tube because we're We're talking about week 4. This is pretty early on. But what's cool is this is going to start to actually form the stomach. So if you looked at that, you'd probably be like, okay, yeah, that's the esophagus. It's just a tube. But this is what it all starts out as. It all just starts out as that gut tube. So it's actually going to start to get longer, and it's going to start to get on this like fusiform shape. So it's going to become kind of like spindly looking. Okay. And that's going to start to form the actual stomach. Now also notice here, you have 2 little buds here and here. These are the dorsal and the ventral buds that are going to form the pancreas. And then next to that, you have a little bud here that's going to form the gallbladder and the bile duct. Okay, so think of where the stomach is in relation to, you know, the gallbladder, the bile duct, and the pancreas. They all start out like this. So we have our stomach getting longer and becoming fusiform, and it's going to look something like this. So it kind of has that fusiform look. But what's really cool is it's also going to rotate. See, so many rotations. But this one is going to rotate like this. And as it does that, it's going to then pull on this part down here, which is the duodenum. And as that's happening, it's going to then kind of pull this part upwards. And that's what's actually going to form the C curve of the duodenum. So you can see the greater curvature starting to form here. We're going to now rotate all of this. And as that happens, this part's going to pull up with it. So what it's going to do here is then pull the duodenum upwards, like I just said, and it'll form that C curve of the duodenum. You ever wonder why the duodenum has that weird C curve? This is why. It's pretty cool, actually. And as it does this, also notice what happens to this ventral bud of the pancreas. So if we go back, it started all the way over here, right? But as that part rotates, it actually like swings the ventral part to the other side, okay? And fun fact, if you care, you know how the vagus nerve, it starts as a right and a left vagus nerve, and they go kind of through the neck and then through the thorax. But then at the level of right around the distal stomach and the esophagus area, they're going to actually turn into the anterior and posterior vagal trunks. And it's kind of confusing because you think, well, it was right and left. How did this just turn into anterior and posterior? And this is exactly why. This rotation makes it kind of pulls the vagus nerve with it and makes it anterior and posterior, which is pretty cool. So we've flipped everything around. We've now formed the C shape of the duodenum. We've flipped the pancreas around. And so what happens next is the 2 parts of the pancreas here are going to fuse together, okay? And so here we now have the ventral bud here and the dorsal bud, which is bigger, it grows faster, and they have now fused together. But look what also happens to the bile ducts. Pretty cool. So it's going to come in and it's going to travel here, and this is how the pancreatic duct here and the bile duct here join and both dump into the major duodenal papilla, or the ampulla of Vater right here. Then, if you remember, you can sometimes have that minor pancreatic duct. That would be this guy here, and that would drain into the duodenum as well. So this is kind of the summary. So we started out as one nice little tube. It's the stomach part here is going to start to get that fusiform shape, and it's going to start to form the greater curvature because this side is growing faster. It's then going to flip around, and as it does that, it's going to pull this part of the duodenum upwards, forming that C shape. And also as it does that, it swings around this stuff to this side, creating the pancreas, 2 buds kind of coming together here. Those then fuse, and that's when you get a full pancreas, and then the bile duct and the pancreatic duct joining. So at this point, we've got all the normal structures, but again, how does this become secondarily retroperitoneal? So at this point, over here in our normal gut tube, that would be suspended by the mesentery as normal. It develops inside the peritoneal cavity. But after it all fuses here, it's then again going to be kind of pushed backwards posteriorly, and it's going to adhere to that posterior or dorsal body wall. And it is then considered secondarily retroperitoneal. So another congenital anomaly that can happen here is pretty cool. It's called annular pancreas. And so remember that we just had two different buds forming this. And so there's a couple different theories as to how this happens, but it typically arises if you have two lobes of the ventral pancreatic bud and they go in opposite directions around the pancreas when they're kind of like swinging around it. And then instead of just coming to this side of the pancreas here, it's actually going to form a ring of pancreatic tissue around the duodenum here. And so this is a picture from a surgical procedure where you can see clearly that the duodenum is obstructed and it's by that pancreatic tissue. So this can have pretty severe clinical effects on the patient, and you can go in and surgically fix it. But this is about 1 in 1,000 to 1 in every 20,000 people that have this annular pancreas. So here you can see now, we talked about the ascending colon and the descending colon and how those get fused to the posterior abdominal wall. And then I just told you how the duodenum and the pancreas form, but then they get pushed backwards and kind of fused to that posterior wall. So this is what it looks like during the development. So we can see here, this would be your pancreas, this would be that duodenum, and notice at this point, they're still inside the cavity. Like there is still peritoneal cavity behind them here. But as it finishes developing, notice that these now fuse to the posterior abdominal wall. So now these are secondarily retroperitoneal, okay? Whereas these guys, so stomach and colon, small intestine, these still all have a mesentery. So here this would be mesentery, mesentery, mesentery. Those are suspending those inside the actual peritoneal cavity itself. So those are still intraperitoneal. So why do we care about all of this? Is this just me kind of geeking out over embryology? Yes and no. So this is really pertinent for surgical pathology. So the reason for this is if something is inside the peritoneal cavity, so intraperitoneal, it's going to be covered by a serosa, right? And we know that serosa is not a true surgical margin. Whereas if something is retroperitoneal, whether it's primary or secondarily retroperitoneal, it's not going to be covered by a serosa, but instead is going to be lined by an adventitia. And so as that peritoneum or that mesentery disappears, it's going to adhere to the wall, and it's basically just loose connective tissue that holds it against that wall. So that's the adventitia. And so for surgical margins, the serosa, again, it's not a surgical margin. So you'd have to find where it's reflecting off. So if this is the gut tube, what I've drawn in the black, and this is your peritoneum lining it, and then it reflects off this way, where it's that double reflection right there, that is your mesentery. So your actual surgical margin in this case would be a mesenteric margin, aka right here. Versus any of the structures that are retroperitoneal, whether it's primary or secondary, these are not suspended by a mesentery. And so in this case, it would be the radial margin right where they're adhered to that posterior abdominal wall at that adventitia. So this can be kind of confusing and difficult to find. So here, this is an example of a mesenteric margin. So this is an ileocecectomy specimen, and you can see this whole surface is lined by serosa. It's kind of glistening. And where that serosa or that visceral peritoneum reflects off, the two layers come together and form this mesentery. So at the very edge of that, where the surgeon cut, you should see either some cautery or something else giving you a hint. That would be the mesenteric margin. So if you look at it from the side, you can kind of tell that that's where the surgeon had to cut. So that would be your true surgical margin. Now the serosa, of course, is important because it's going to upstage the cancer if the tumor is extending through the serosa here, but your actual surgical margin is out here at the mesenteric margin. So this is kind of tough to see even on pictures. So I have another short video. It's only like 4 minutes, but hopefully we can get that one to play too.
Yep, I'll go ahead and get that started for you.
different margins. So if I'm a surgeon and I have to physically cut this out, all of this is flopping around. This is all just within the peritoneal cavity, flopping around. So on the outside of this, it's covered by a visceral peritoneum or a mesothelium, which means that it's covered by a serosa. So if I take a section of the inside to the outside of this, or like a circumferential cut of this, you're not really going to have a true surgical margin. That's just going to be, let's say, tumor in relation to serosa. Same thing over here. This is the cecum. You know that because you can see the little appendix right here. So the cecum is nice and floppy. It's just kind of hanging out here. So if I'm a surgeon and I got to cut this out, I can literally just pull this out right here. It's already loose. So if I need a surgical margin here, where your surgeon is going to have to cut is physically here along the mesentery. So this fat and these vessels inside this fat are your margin. So for small intestine here, so right here we've got jejunum and ileum. This is the end of the ileum. All of that has a mesenteric margin, but so does your cecum here because it's floppy, right? So now we have removed the majority of the small intestine. So we left the duodenum and the first little bit of the jejunum intact. We've left the terminal ileum intact. But now you can really see what's going on with the colon. So this is all the mesenteric fat that we just cut to remove that small intestine. So notice this mesenteric fat does connect to the colon over here too, right? It connects all the way over here. You have more mesenteric fat here because a mesentery is literally just a double fold of peritoneum. So all of this is still mesentery. Now I'm going to cut this out so that you can see just the colon. So here you can see this is the end of the duodenum. The head of the pancreas is right here. Here's where the superior mesenteric vessels have been cut. So now if you look at the anatomy of the colon, this is where the margins come into play. So here, this is terminal ileum, cecum with appendix, right? So this is nice and floppy. It's not attached to the posterior abdominal wall. This whole part of this is loose and floppy. Notice this is the ascending colon or the right colon. If I try to pull on this, it is literally stuck to the back of the abdominal wall. So this is your posterior abdominal wall. It is fused there. So if I'm a surgeon and I have to cut, I will literally have to cut through all of this to remove the ascending colon. So right here, you can see the difference in the margins. So for your cecum, this is not attached. All I have to cut if I'm a surgeon is this mesentery to get this chunk out. If I want to take out the ascending colon, not only do I have to cut all of this, but I have to cut back here. Because I'm cutting it, this is now a true surgical margin. So this is why the ascending colon has a radial margin and the cecum does not. Then if you go to the hepatic flexure, you can see that it's the same thing here. So the transverse colon, I can flop it around all I want, right? This is intraperitoneal. Cecum is intraperitoneal, transverse colon, intraperitoneal, floppy. When it turns now, it's turning at the splenic flexure, and now it's going to the descending colon. So this is the descending colon here. Can I move this around? Can I flop this around? No, it is literally fused back here to the posterior abdominal wall. So again, if I'm a surgeon, if I have to cut, I have to cut along here. That means that this has a radial margin. This does not. This would have a mesenteric margin, because if I want to cut out this part of the colon, the transverse colon, I have to cut all of this. That's your mesentery. That's your true surgical margin. And then lastly, once we get down here to the sigmoid, look how floppy this is. So again, this is floppy. This is intraperitoneal. This is going to have a mesenteric margin. So here, if I'm the surgeon, I have to cut this part. I don't have to physically cut on the outside of that sigmoid colon at all because it's not fused. And then we're going to get down into the rectum. So to recap, we have cecum, transverse colon, and sigmoid, all floppy, all mesenteric margins. On the right and the left, we have your ascending and your descending colon. Those are literally fused to the posterior abdominal wall. Those are going to have radial margin.
All right, that's the end of that video. Again, excellent demonstration. Go ahead and continue with your presentation when you're ready.
Alrighty, that is almost it, actually. So here we have just that same picture to kind of reiterate those margins. And hopefully now that we've talked about the embryology and how all of this actually forms, you can really understand the difference between something that is actually retroperitoneal, like, for example, the lower part of the rectum because it's developing below the peritoneal cavity. Same thing with the bladder and the esophagus up here, because it never starts to develop inside the actual peritoneal cavity. Versus everything in yellow, these all develop inside the peritoneal cavity and stay in the peritoneal cavity. And then the pink, those are secondarily retroperitoneal, so they start inside the peritoneal cavity, but essentially get forced backwards and fuse against that posterior wall. So hopefully that helps understand the surgical margins. And I just want to give Ian and his team a huge shout out. I mean, this event is awesome, and I know it takes a lot of work to put this on, and especially figuring out all this technology. And I just want to thank you for putting it all together and also for having me. I had a lot of fun putting this talk together, and I hope that it helped. So if anybody has any questions, I'm happy to answer.
That was absolutely amazing, Sarah. I had no idea that you would be, drawing on your own slides live like that. But that was really, really impressive, really well explained, especially with the second video and, describing what's retroperitoneal and what's intraperitoneal. I think for myself and a lot of people, that's going to be, the most straightforward presentation of that information. So thank you so much for doing this talk.
Yeah, absolutely. I'm glad you enjoyed it.
All right, so we're gonna stick around for a little bit just to answer any questions that might come up. I do want to ask, how long did it take for you to get so comfortable with all of this knowledge pertaining to embryology? I feel like the gut structures in particular are really difficult to keep track of because everything, like you said, is swinging around inside of the body and rotating and shifting. Was there any sort of key information or key study practice that allowed you to understand the embryology?
Well, I am, I think, physically incapable of memorizing things, and I always have to actually understand. And so in anatomy, when people are like, oh, this is, retroperitoneal or intraperitoneal or whatever, I feel like when they teach it or when you're learning it as a student, it's not very straightforward at all, as we just saw. And so I think a lot of people just kind of memorize it. I mean, who remembers that mnemonic sad pucker, right? But for me to actually know things and be able to do well and explain it, either back when I was in school or if I'm trying to explain it to a student, I have to actually understand it. So originally when I was trying to learn this stuff, I went back and learned the embryology to actually kind of figure it out for myself. And then once I got into Path, when we were talking about all the margins, I wanted to know why they were certain margins instead of just kind of remembering, oh, these certain areas have certain margins. And so it definitely was not a quick thing. This has been a while, but it also helps because I teach this stuff kind of regularly. And so I feel like if I didn't teach this on the regular, I would definitely have to review it a lot. But because I teach it, probably once a semester at least, it luckily stays fresh in my head and I don't have to really relearn anything.
Right, so one piece of advice might be to become a professor at a major university.
Well, I don't know if I'd recommend that.
Well,
it's the best and the worst all at the same time. But I guess my advice would be repetition. That's always my advice for learning things.
Yeah, exactly. I think that the understanding of how things work and also being able to apply that knowledge to a practical level more so than simply memorizing things goes a long way, and it really helps with actually doing your job and understanding why things are the way that they are and why you have to do things a certain way as a PA. Okay, so it doesn't seem like there are any questions, so I want to thank you very much, Sarah.